If we are all on, can we start?
Yes, doctor.
Hello. I'm getting a feedback sound. Is there,
Yes,
can somebody
can
regulate
start.
that? Hello, are we all on? Hello.
We can hear you,
Doctor,
I don't know whether the class is there or they have left.
We are there.
You are getting me.
Yes, yes, doctor.
And then now are you seeing my screen?
yeah, we can see.
It's your pathway.
Yes, okay, fine. Then let's proceed. So this afternoon we shall talk about visual pathway, and the pathway which takes the retina from the retina to the occipital. My screen is again not moving. Unfortunately, my screen is frozen. Okay. So the is a pathway of nerve fibers from the retina which will transmit the visual stimuli to the and is made of the optic body and optic radiation. The objective is to describe the anatomy and the visual pathway. We also want to describe the optic nerve, that is visual field, and describe the relation that I think we are seeing here. The pathway is I wish I could make it smaller, but maybe the picture, if we get the picture later, we may. And this is the pupillary pathway showing how the pupillary fibers branch off from the midbrain. The optic nerve is the first segment of the visual pathway and is made up of 4 segment portion, where the optic nerve 2.5 to 1 millimeters in length. The second portion, which is the longest part of the obvious or science course within the orbit, to make the optic nerve flexible as the eyeball moves. Then the third portion is the canalicular portion, which is within the optic canal, the bony canal, and that measures about 10 millimeters in length. Then the last portion of the optic nerve is the one which now enters into the cranial cavity, the anterior cranial fossa, which is the intracranial portion, and it's about 9 millimeters in length. The optic nerve is accompanied by branches of the ophthalmic artery, that is the posterior ciliary arteries, the glial arteries, and the central retinal artery, and is surrounded by meninges until its exit from the sclera. So I'm now talking about the abnormalities of the optic nerve. The first one is optic neuritis, which refers to the inflammation of the optic nerve, and the causes, in about 30 to 50% of the cases, no known cause can be identified. Those are idiopathic. The other causes are autoimmune diseases, like we see them in ankylosing spondylitis, multiple sclerosis, Crohn's disease, and so many others. Then the other portions, of course, is the infective causes, which include viral infections. We have seen them in the herpes infection, CMV, retinitis. We have seen HIV and other viral infections. Bacterial infections like tuberculosis and syphilis, but all these causes account for less than 10% of optic. The presentation, there are broadly two clinical types of optic neuritis. The clinical we have and inflammation will involve, you can see the inflammation. That's why then where inflammation is up to Papillitis, where I said inflammation involved the head of the optic nerve, and it is usually unilateral in adults. That means that only one eye is involved, but in children it may be bilateral. And the patients usually present with sudden onset of poor vision, and they always have some dull pain when they move their eyes. So they complain of dull eye pain when they look up, down, or on the sides. And when you examine them, they always have a reduced visual acuity, which depends on the extent of the inflammation. If the inflammation is very severe, the vision may be very poor. In mild inflammation, the vision is also mildly affected. And there is always relative afferent pupil defect. That is because the fibers of the optic nerve are being damaged by inflammation, then the amount of pupillary reaction on that eye is reduced. And on fundoscopy, you see a swollen and hyperemic optic nerve head, the margin of the disc. So the disc margin is blended with the surrounding retina, so you don't see a clear, distinct margin where the optic nerve head ends. That's what we call blurring of the disc margin. And the cap, the normal cap within the optic nerve is obliterated because of the swelling, the edema. The picture is again too big. As you can see, you don't see a clear margin of the optic disc. You see those engorged blood vessels, they're coming from the center, but you don't see where the disc margin is ending. And there's no cap at the center of the optic disc, and that's what I was meaning. Treatment of optic neuritis. As we looked earlier at the causes of optic neuritis, we saw that majority of the causes are idiopathic inflammation, while about 30%, again, over 30 to 40% of the causes are autoimmune diseases. So most of them are just immunological inflammations. And so you don't need to wait for the results of investigation. You can just go straight and treat the inflammation to prevent damage to the optic nerve. So the mainstay of optic is by use of systemic anti-inflammatory drugs, preferably steroidal, in a dose of 1 to 2 milligrams per kilogram body weight as a single morning dose, and you taper the dose with clinical response. Complications which may arise from optic neuritis, and the commonest complication is the optic nerve atrophy. And optic atrophy usually appears after 4 to 8 weeks following the onset of the disease. And when you look at the nerve is pale white. That's when you say the nerve has atrophied. There were a lot of clinical trials that were done using multiple sclerosis or the use of systemic steroid, and it was shown that the steroid does not alter the outcome of the treatment of the disease, but the only thing the steroid will do is to fasten the time of the outcome. So if you are supposed to become blind and get optic atrophy, steroid will make it faster. If you are supposed to recover fully, steroid will make you recover faster. That's what we mean by fasten the outcome. So the main determinant of the outcome of optic is actually the vision at the time of presentation. If you present a patient who presents with very poor vision, will always have a poor outcome. A patient who presents with good vision will always have a better outcome after steroid treatment. The second abnormalities of the optic nerve is the papilloedema. Papilloedema is actually not a diagnosis. It is just a clinical sign. The diagnosis of the underlying cause of papilloedema is what you need to find. So you don't need to get excited when you see a patient with papilloedema, because there is a bigger underlying problem behind that. It simply refers to the bilateral swelling of the optic nerve head due to raised intracranial pressure. So for you to make it to report that a patient has papilloedema, you must have looked at both optic nerves in somebody's eye, and both of them should be swollen. But there are also some other accompanying features which are different from neuritis. Yes. So the cause of the raised intracranial pressure is a diagnosis. So for example, you have space-occupying lesion or tumors, you have severe hypertension, and many others. Intracranial inflammations, meningitis, head injuries. So those are the cause, those are the diagnoses. But papilloedema is just a finding as a sign to raise suspicion. Papilloedema is therefore always, unlike in papillitis, which is usually unilateral, papilloedema is always bilateral, because if there's a raised intracranial pressure, the pressure is transmitted equally through both optic nerves. And so the swelling of both optic nerves must appear. And the treatment for papilloedema should be geared towards the cause of the raised intracranial pressure. So you can see there, as you look at the picture, the optic nerve head is swollen, but in this case, it's not due to inflammation. It's just due to accumulation of fluid, CSF, because of transmission of the from the brain. Before I go to that, there is a way you can differentiate between papilloedema and neuritis, because I said sometimes optic neuritis in children is bilateral. And so how do you differentiate between bilateral optic neuritis and papilloedema? Papilloedema will not always have a relative afferent pupil defect, because there's not much damage to the optic nerve fibers. And so the visual acuity in papilloedema is usually normal at the beginning, pupillary reaction at the beginning. But in the long term, then when optic nerve fibers begin to get damaged in papilloedema, then you also get visual problems and pupillary reaction abnormalities. But at the beginning, you can distinguish between papilloedema and bilateral neuritis by one, papilloedema has got normal vision, while papillitis or neuritis has got poor vision. Papilloedema has got normal pupillary reaction, while papillitis has got afferent pupil defects. I will just only name some few congenital optic nerve abnormalities. If you remember the embryology of the eye, the optic nerve is the extension of the optic vesicle from the neuroectoderm, where the optic vesicle hangs onto the neuroectoderm. And as the optic vesicle enlarges, there is a cleft in the optic vesicle, which is called the choroidal fissure, where these mesodermal cells migrate from the neuroectoderm to fill the space in the eye, forming the vascular tissues of the eye and so on. So sometimes in the development, the fissure, the optic fissure, the choroidal fissure fails to close. and you end up getting abnormalities. And this, some of these abnormalities include optic nerve agenesis or dysgenesis. Agenesis means completely absent nerve, or dysgenesis means that it is poorly developed. You have optic nerve coloboma, which is a direct consequence of failure of closure of the choroidal vessel. You also have the neurofibers spread beyond the margin of the optic disc and into the surrounding tissues, the retinal tissues, giving you like a flower in the morning, what's called morning glory syndrome. You can also have a tilted optic disc where this is not flat behind the eye, but is tilted to one side. All those are congenital abnormalities of the optic disc. Some of them affect vision, others don't affect vision, depending on the degree of the abnormalities. Basically, that is all about commonized optic nerve diseases. Our other objective was to look at the visual field. I would like you to appreciate one thing, that if you don't understand this, what we are going to go through right from the beginning now, then if the whole thing we are going to talk, you will not pick it, because you need to understand the anatomy of the visual pathway. You need to understand the principle behind visual field. What does visual field present? In a functional view, the visual field is the orientation in space. Retinal fibers orient into space their functions. If some fibers are not working, then that part of the field of vision will also not be present. And the visual field, therefore, is exactly the opposite of the anatomical topography of the retinal nerve fibers. What do I mean by that? For example, if you look to the right side of your face and you draw a line from that object you are seeing on the right side of your face, on your right eye, the light rays will pass through your pupil and will fall onto the nasal part of your right retina. If everybody is hearing me, you can do that practice. Look something on the right side of your face, draw a line from that object to your eye. It will enter your eye and the light rays will fall on the nasal part of your retina. I'm saying we divide the retina into two, the one towards the nose, the temporal bone. So the light rays from your right field coming to your right eye will fall onto the nasal part of your right eye, while the same ray will fall onto the temporal part of your left eye. See? So if you are talking about the right eye and right field, the visual field for the right eye, the fibers responsible for the temporal field in the right eye are the nasal fibers. So the visual field is for a particular eye in that direction is opposite. We shall look at the diagram. Oh, it is so big that I can't bring it down. So you look at them. These are examples of visual fields. As you can see, the visual field has got key landmarks. There are two perpendicular lines. Yes. And then you'll have one small cross just below it. So the two perpendicular crosses are just showing you the vertical and horizontal parts of the retina. And then the center of the two crosses, where the two crosses meet, is the center of fixation, which is the macula. So optic nerve field defects. What we have shown there is a generalized scotoma crossing the midline. There are so many of them. My pictures are too big, so you can't see very well, but I believe that if you get a better picture of the presentation, you will see what I'm meaning. So you can see the one below, B, you see that the field defect is, yes, I'm seeing that Robert is raised a hand. What is it, Robert?
Good afternoon, doctor.
Good afternoon.
I could request for the first slide, and which, if at all there's a pointer, you try
I don't
to.
have a pointer here. Which slide? This one? Or this one?
No, the previous one.
This one?
Yes.
Yes. What
So that
what did you want to see in the first slide?
there this one of numbers, then the other one of shading, the dark
Yes.
part, I'm not really comprehending anything.
Yes, actually, if you would, it is very difficult for me to explain all this one. Actually, the visual field, there is an intensity of light which the retina can perceive, and it varies with age. And so when they are presenting the stimulus, the amount of stimulus presented at that particular point is the one recorded there. And then if you perceive that light in the same intensity, then it is recorded as normal figure. So they are in figures. It goes up to 1, 2, 3, 4, up to 8 or 9, showing the amount of intensity. If you need more light for you to see the same spot of light, then it keeps on removing that number. So the number becomes less and less until it goes to 0. That means that you could not even see that light intensity as per threshold. It will take a long time for us to understand that the interpretation in terms of figures. But it is now this figure here which is now mapped into shades of color, which you will see on the right side. That is now when they're mapping it to show you the shades. If the color is dark, that means that you could not see. If the color is like on the right side of the second drawing, on the shading, you see that one is more white. That means that the patient was able to detect at a certain better intensity as compared to the one on the left side. So those are shading, and those ones are given in terms of figures of intensity. When you look at the diagram down, you can see that on the right side, the figures are all low. Some of them are even in minus. So that shows that the intensity has gone very low. So that's how we report about visual field. I wish if those who come for the clinic, they can ask for a demonstration of the visual field so that you can appreciate those figures and the drawing, the shading. Yes, can we proceed? So now here we are showing, we are now, the diagram is showing us those defects. As you can see, you see minus 30 on the upper part here, minus 30, minus, all those are showing that they are variants. And then when we map them in the lower drawing, you can see that there's a pattern of scotoma, which is mapped only on one side of the field. So that is how we do the mapping, and then we interpret the field defects. So now we can now look at general defects, what happens to the various segments of the visual pathway and how they affect visual fields. Now we start with the chiasma. Chiasmal defects are commonly seen in advanced pituitary adenoma. That's the most common cause of chiasmal problems. But also you can see chiasmal problems when you have issues with the carotid artery, like carotid cavernous fistula, because both the carotid arteries lies in the cavernous sinus within the frontal, within the anterior cranial fossa, and therefore they can also have effect on the chiasma from both sides. But the commonest is the advanced pituitary adenoma, which enlarges from, because the chiasma actually lies directly above the pituitary fossa. And so as the pituitary gland enlarges, it compresses, and unfortunately, we should have seen the visual pathway, because in the visual pathway, we have the fibers from the retina. The fibers from the retina, which are arising from the nasal part of the retina, remain nasal in the optic nerve, but they start crossing over in the chiasma. So they cross over in the chiasma to join the contralateral optic tract. So you have the right, if you have the right eye, nasal fibers of the right eye remain nasal within the optic nerve, cross at the center of the optic chiasma and ends up into the nasal aspect of the left optic tract. While the reverse is true also for the left nasal fibers. The left nasal retinal fibers remain nasal within the left optic nerve, cross over in the chiasma, and join the right optic tract. And when they're in the right optic tract, they also remain nasal within the optic tract. But temporal fibers of the retina remains temporal throughout the visual pathway. That means that they are temporal within the optic nerve, they remain temporal within the optic chiasma, and they remain temporal within the optic tract. And they remain in the same tract. If they are right, they will remain in the right. They never cross over to the fellow visual pathway. Therefore, when we have advanced retinal adenoma, we get damage of the nasal fibers from both eyes, which are crossing over at the center of the chiasma. And so, since the nasal fibers are responsible for the temporal fields of vision, you are going to have bitemporal hemianopia. That means that temporal field defects will appear in both eyes. And that will be typical of chiasmal lesion, bitemporal hemianopia, which we also call it heteronymous hemianopia, because they're on opposite side. Again, the pictures are quite big, as you can see from the drawing. Is the one inferior, where it is labeled right and left. You can see that the field defects are on the right side and on the right side. So they are temporal, actually by temporal hemianopia, which is actually not heteronymous, but homonymous hemianopia, because they are on the same side. So it is homonymous. Then we have the optic tract lesion. Optic tract lesion. This shows, the visual field here. This visual field is for, it is actually optic tract abnormalities, not optic nerve, not optic chiasma, because I can see they are on the right. For the right eye, it is on the nasal side. For the left eye, it is on the temporal side. So it is homonymous, but they are not on the same side. The optic tract lesion shows same-sided field defects, because as we have seen, in the right optic tract, the right optic tract contains the right temporal fibers, while it also has the left nasal fibers. That is what is found in the right optic tract, because I said the nasal fibers cross over in the chiasma. And so when they reach the optic tract, we have nasal fibers from the contralateral eye, and then temporal fibers from the ipsilateral eye. So on the right optic tract, we have the right temporal fibers, left nasal fibers. And therefore, as we talked earlier, we said temporal fibers are responsible for nasal field of visions, while nasal fibers are responsible for temporal fields of vision. Therefore, what do we see in the right eye? Since the temporal fibers are the ones damaged in the right optic tract, we shall see right nasal field defect, while on the left eye, we shall see left temporal field defects, which is what we saw here, what is there. So this is typical of optic tract lesion. The right eye, which has got the temporal fibers, will have a nasal field defect, while the left eye will have a temporal field defect. So this is one we call homonymous hemianopia, typical of optic tract lesion. So I've said earlier, so same-sided field defects or homonymous hemianopia, and is usually caused by vascular disorders or brain tumors. So the commonest problem, because where the optic tract is located within the midbrain, and the problems in the midbrain are purely vascular problem, where the circle of Willis, the posterior communicating arteries, the superior cerebellar artery and cerebral arteries are the ones where those visual fibers pass, and their aneurysms can cause problem, or sometimes they can get tumors. So basically, that is how we see abnormalities of the visual pathway, the visual field. Yes. Yes, Geoffrey, Godfrey. You have a question? Very Godfrey, you have a question, please? Go ahead.
I beg your pardon, Doctor. On homonymous hemianopia. I've not understood you well. I'm confused a bit.
Okay. Homonymous, that is when we say something is homo, as we can use the word homosexual or homo what? Homo means the same side, the same thing, isn't it? So when we talk about homonymous hemianopia, that is hemianopia means half field defect. Then homonymous means that they are on the same side. And as we can see from here, all these defects are on one side, isn't it? When you look at the diagram below, the diagram inferior here where it is right and left. The left is the left visual field, the right is the visual field for the right eye. And for the right eye, because when you draw a visual field, the one towards the center of the two eyes is the nasal field, and the one on the outer side are the temporal fields. So for the right eye, it is a nasal field which is affected, while for the left eye, it is a temporal field which is affected. So the field defects are on the same side. If you look at it, they are all, if I put them on my right, if I say they are on the right side of the field, so they are all appearing on the right side of the field, and yet for the right eye, it is a nasal field, for the left eye, it is a temporal field. That's why it's called homonymous hemianopia. Whereas for chiasmal lesion, because all of them are nasal fibers, you're going to see temporal fields, defects. So for the right eye, you're going to see the defect on the other side, and for the left eye, you're also going to see the defect on the other side. So they are all bitemporal hemianopia. That is typical, which is called also heteronymous hemianopia. They are hetero because they are on the opposite side. That's what you see. I don't have the diagram here. I will leave it somewhere, but you would have seen. But they should be on the opposite side, on the temporal side, on both sides, because all it is the nasal fibers in the chiasma which are all damaged, and nasal fibers are responsible for temporal fields of vision, and therefore the defects will be on the temporal side of both fields, and so we call them bitemporal hemianopia. But since they're on the opposite side of the field, then they are called heteronymous hemianopia, typical of chiasmal lesions. Yes, we look at the pupil and vision. Unfortunately, the diagram which I showed earlier does not bring us very clearly the relationship between the pupil and the pupillary fibers and the visual fibers. I'm trying to go back. So these are the visual fibers, but it is too big to fit into this screen. I can't really bring it down. And then these are the pupillary fibers. The pupil fibers branch off from they travel together. Actually, the pupillary fibers are together with the retinal fibers. Joining the optic nerve, they are together with the visual fibers within the optic nerve. They move to the optic chiasma. Some of them cross over at the chiasma, and they come up to the optic tract. It is in the optic tract where the pupillary fibers now branch off and leave the visual fibers to continue to the occipital cortex. So the visual fibers will continue to the occipital cortex, whereas the pupillary fibers will branch off at the level of the midbrain to the pretectum. So they join the pretectal nucleus, and then eventually they join the third nerve nucleus. So that is what makes the pupillary. There is something common with and vision, because they up to the level of the midbrain in the optic tract, where the pupillary fibers will branch off to the pretectal nucleus, and the visual fiber continue to the occipital cortex. And so when you have cortical abnormalities, cortical problem, for example, injury affecting the occipital cortex, you will always have a patient presenting with poor vision. But the pupil in those patients will appear normal because the fibers of the pupil don't reach the occipital cortex. So in cortical problems, vision is affected, but pupil reaction remains abnormal, remains very normal because pupil fibers don't reach the occipital cortex. However, if you have problem within the midbrain up to the optic nerve, you will always get abnormal pupil and abnormal vision. And that's how we make a diagnosis of cortical visual impairment and blindness, just by doing pupillary reaction and checking for vision. You find a patient presenting with very poor vision and the pupil reaction is abnormal, you should know that the lesion is within the occipital cortex. And that's what, so we call that cortical visual impairment. So that is it, unless we have I hope we have answered our objective. We have described the visual field and the abnormalities, and we have described relation between vision and pupil reactions. I'm sorry if anybody had a question because my network went off. So if you have any questions, please just go ahead. My network was off. Yes, I'm back.
Thank you, Dr. John. My question is, how do I explain papillary reaction in a head injury? Say if somebody has an epidural hematoma, is on one side, maybe the temporal region, but their manifestation is in the eye, the contralateral eye.
What I was talking about here is a papillary abnormality with the cortical or occipital lesion. But if you have head injury involving the other parts of, like parietal part of the brain, you are almost, the head injury is affecting mainly the midbrain. And in that case, you are going to get maybe epidural or subdural hematoma, and that one causes effect on the cavernous sinus, and you are going also to have abnormal pupillary reaction on top of, but sometimes the vision remains normal. So for me, I'm talking about occipital damage with pupillary reaction. But if you're having damage in the parietal area, you are most likely going to have abnormal pupillary reaction together with the, most likely again, the reverse of what we talked about. The vision might remain normal if the visual fibers are not affected, but there's compression of the third nerve. As we know that the oculomotor nerve, after leaving its nuclei at the midbrain level, it passes through the red nucleus in the bacilla, that's what we call the bacillar portion, and then it passes where the blood vessels are, and then it passes at the flow of the third ventricle. It is the flow of the third ventricle where the third nerve is prone to damage in subdural or hematomas. Yeah, so you're going to have abnormal pupillary reaction because of the third nerve fiber damages. But vision may be normal in this case. But if you have in the occipital cortex, you are going to have abnormal vision, but abnormal pupil. So depending on the location of the damages, the presentations are quite different. Yes, any question?
Thank you, Doctor. I have a question.
Yes, please.
So, the pupillary and the visual, pathway, they take along the same route up to the midbrain. So I'd like to know that if we have the optical tract lesion, does that mean that we shall also have a defect in the pupillary with defects? And if it occurs, does it occur on the same side, contralateral side, or both sides?
So I wish you get louder because I'm not getting you well.
Okay, Doctor, I'm saying that the pupillary pathway travels along the posterior pathway as they are fed up to the midbrain.
I've not got your question, sister. I'm very sorry, I can't get it. It's breaking. Members, I'm sorry, I didn't get that question, so I can't answer it. Unless there's any other question, I will sign off. Okay, thank you very much. If there are any concerns, you feel free to contact me. We close the meeting.